Okay, this lecture will be on the hepatobiliary system, and you'll have some objectives that you'll need to be able to define. Going right into the anatomy and physiology, we're looking at the liver, stomach, pancreas, and gallbladder. For this lecture, we're really focusing on the liver, the gallbladder, and pancreas. We'll be including the spleen in that also. So the hepatobiliary system includes the liver, gallbladder, biliary tree. Pancreas is closely related and shares a portion of the biliary ductal system. So the liver is the largest organ in the body. It's sheltered by the ribs. It's in the right upper quadrant. It's kept in position by peritoneal ligaments and intra-abdominal pressure from the muscles of the abdominal wall. So the function of the liver is metabolism of substances delivered via the portal circulation, synthesis of substances including those concerned with blood clotting, storage of vitamin D and other materials, and detoxification and excretion of various substances. So the liver, also the hepatic artery and the portal vein. So the hepatic artery usually originates from the celiac axis, and it takes oxygenated blood to the liver. The portal vein is formed by the union of the superior mesenteric and splenic veins. It's located within the liver and serves to return venous blood from the abdominal visceral to the IVC. So the biliary tree is a system of ducts that act to drain bile produced in the liver into the duodenum. So bile from the liver's two main lobes is drained by the right and left hepatic ducts. These unite to form the common bile duct and is joined usually in its mid portion of the cystic duct from the gallbladder. And I'll show you diagrams on how this all fits together. So the cystic duct and the common hepatic duct form the common bile duct. So looking here, we have the right hepatic duct, the left hepatic duct that come together in a Y to form the common hepatic duct. So you have your cystic duct that drains the gallbladder, and it merges with the common hepatic duct for the common bile duct. So you have the right and left hepatic duct that come together to join the common hepatic duct, and where the cystic duct joins in, it goes to the common bile duct. You have your sphincter odi down here, and you have your pancreatic duct coming up off also. Here is an MRCP, that's funny, of the biliary tree, and you can see your right and left hepatic duct to your common hepatic duct. This is your cystic duct, and that is common that it's real twisty, turny, curvy, and that's where the stones get stuck. Comes together for the common bile duct, and this is an excellent shot of the pancreatic duct. So this is your pancreatic duct right there. This is your kidney collecting system right here. This is your bowel. So if there is pancreatitis, you're going to have a ton of fluid all through here, and it's really, really hard to see your ducts when there is pancreatitis. So the biliary tree, the shortest portion of the common bile duct after joining the pancreatic duct, is also known as the ampulla vator. So the flow of both bile and pancreatic juices join the duodenum into the duodenum is regulated by the hepatopancreatic sphincter known as the sphincter of Odi. So looking here, we have your right and left hepatic ducts joining the common hepatic duct. This is your gallbladder, and this is your cystic duct. It's not this straight as you saw on MRI, and it joins in with the common hepatic duct to do the common bile duct. Coming down, you have your ampulla vator, and here's your pancreatic duct. So the gallbladder. It is a digestive organ. So it's pear-shaped, and it's a sac located in the undersurface of the right lobe of the liver. The walls are thin and less inflammation is present. The sole function is to store and concentrate bile that has been produced by the liver. So it receives bile from the liver via the hepatic duct. The pancreas, it's elongated, flat organ that obliquely crosses the left of the abdomen behind the stomach. It has powerful digestive organ, and its functions are both exocrine and endocrine. So it discharges throughout the pancreatic duct into the duodenum, and it produces insulin and glucagon to regulate carbohydrate metabolism. So, imaging considerations. We can do radiographs. There's percutaneous transhepatic colonography. There's endoscopic retrograde pancreatiogram, so ERCP. So it's not often that we say the whole thing. We just refer to it as an ERCP. So in MR, we call it an MRCP instead of an ER. So instead of using a scope, we're just using the magnet. There's operative cholangiography. There's diagnostic medical sonography, and sonography typically is our first go-to when we're dealing with the common bile and the pancreas and the gallbladder. So there's CT. We do see a lot on CT also, nuclear medicine, and MRI. So looking here, this is an ERCP. You can see the scope coming in and down and going through the ampullator, and you can see these filling defects, and that is typically a stone from the gallbladder. So you can see a piece of the cystic duct coming off here. This is your pancreatic duct coming off. So they take a little catheter and they put it in there and they inject contrast. So we have filling defects, which tells us that there's something in there, and it's dilated, so it's being blocked. You can kind of see the rounding of a stone that would be blocked in there. All right, gallbladder pathology. So we have gallstones, just cholelithiasis. So we have acute cholecystitis. We have emphysematous cystitis and porcelain gallbladder. So two major types of gallstones. There's cholesterol, which is predominant typically here in the United States. And it's usually a family history. You're over 40, you're overweight, and you're female. So there's the F's. So female, fat, and 40 are the things that are the triggers typically for gallstones. So ultrasound is the imaging modality of choice for diagnosis. And looking here, so here is the sac, the gallbladder, and you can see we can make a necklace out of all these stones. And up in here, they're in the duct, and this is not good. So, all right, here's ultrasound, and you can see a stone within the gallbladder. Acute cholecystitis is acute inflammation of the gallbladder. It's usually caused by cystic duct obstruction of a gallstone, and ultrasound and nuc med are the best modalities for that. Here is nuclear medicine, so you can see the gallbladder here. It's a nice shot. Okay, emphysematous, I say it, it's hard, cholecystitis. So what it is, it's a rare condition that occurs when stasis, ischemia, or cystic duct obstructions from stones or whatever allows the growth of a gas-forming organism in the gallbladder. It occurs most commonly in elderly men and in patients with poorly controlled diabetes. So KUB is the best way to see it, and it shows us the lumen. So as you can see here, we have air. This is air. On X-ray, air is black. So we have air within the gallbladder. So not good. Okay, porcelain gallbladder refers to calcification of the gallbladder walls. It's caused by chronic cholecystitis, and the walls become fibrous and then calcify. So you can see actually here we have it's been calcified, so we can see it really well. This is called porcelain gallbladder, and you can see it here, porcelain gallbladder. So the main concern is that we need to make sure that it's not cancer. So cancer can be this also. So we got to rule out that and just make it porcelain gallbladder instead of gallbladder carcinoma. So here are your different summaries of the gallbladder pathologies. Now we're going to go into the liver pathologies. We have hepatitis, cirrhosis of the liver, hepatocellular carcinoma, and hepatic metastasis. So hepatitis is the most prevalent inflammation disease of the liver. So it's usually from viral infection or reaction to drugs or toxins. There's different viral types of hepatitis. There's A, B, C, and E. And healthcare workers are at risk for hepatitis B, so HBV, and we require that all of you guys get the vaccine. It's transmitted through contaminated blood and blood products and sexual contact. So the vaccine is available and it is required. You can sign a waiver, but I really don't recommend that. So cirrhosis is referred to the chronic destruction of liver cells and structure with nodular regeneration of the liver and parenchyma and fibrosis. So as an end-stage liver disease, the major cause is chronic alcoholism. So usually 10 to 20 years of alcohol abuse, but it also depends on how much you're drinking. So we could have a person who's been drinking for 2 years, but they're drinking a lot and they're drinking a really hard alcohol, and that can cause cirrhosis faster. So fibrous connective tissue replaces the destroyed liver cells with cells that have no liver function. So other causes can be viral hepatitis, hepotoxic drugs and chemicals, biliary cirrhosis, and hemochromatosis. So some characteristic symptoms are ascites, so fluid collection in the abdomen. So you'll see people walking around with these big, huge abdomens, and they're hard as a rock. So that's fluid backing up, and we call that ascites. It's incurable and irreversible. So some people get liver transplants. If they're still drinking, they're not a candidate, so they have to stop drinking. All right, imaging appearance of alcohol cirrhosis is a large amount of fat accumulates within the liver. So the normal Hounsfield units, if we're measuring the density of the tissue using CT, or we can see it in MRI, if we're looking at the density of that tissue, it's going to be a lot more dense. It's going to be darker. So fluid accumulation within the abdomen and the large breasts due to female hormone secretion. So a lot of these men will have breasts, and it's because of that. So if we look here on this liver, so this is the liver and this is the spleen and here is the stomach, and there's always air within the stomach. That's normal. Don't think that's abnormal. So this is your stomach. It's a muscle and your spleen. And you can see that the liver should be the same basic density as the spleen. So I always look at the spleen for a reference when I'm looking at the liver to see, is the liver darker than the spleen? And yes, this is. So this is a fatty infiltrated liver. So they are in liver failure typically, okay? So hepatocellular carcinoma is a primary liver cell cancer. It's not a metastatic cancer, it's primary liver cancer. It's most common in those with cirrhosis. CT is the modality of choice. We do MRI for these patients also. And we can see here, we have the spleen, and here's our tail of the pancreas, and here's our stomach. And you can see this is liver, normal liver here. Well, I should say it has some fatty infiltrates in it, but here's our liver, and then you can see this big, huge mass right here. So this is a big problem. So this is a primary liver cancer. So not good. Hepatocellular carcinoma. All right. Hepatic metastasis. So what it is, it's the most common malignancy of the tumor, and usually it is a cancer that has come from another area. So ovarian cancer, prostate cancer, pancreatic cancer, and it's spreading throughout the body. Well, the liver's job is to filter out toxins and to get rid of foreign substances from the body. So what happens is it's filtering out of the body and it attaches to the liver, and there you go. So looking here on hepatic metastasis, this is what it looks like on CT. So we'll see blotchy forms of tumors. So this is very, very common when we're looking at metastasis of cancer. So it goes to the liver, and this is the primary of what it looks like. And as you saw on the primary hepatocellular carcinoma, it was just one big mass, one big ugly mass. Whereas these guys, you can see It's just all over, all over. And that's typical. And you can see on ultrasound all of the tumors. So there's a bunch of them. All right, so here are the different pathologies of the liver. Right here. Okay, so let's talk about the pancreas. So pathology of the pancreas. We're looking at acute pancreatitis, chronic pancreatitis, pancreatic pseudocyst, and cancer of the pancreas. So acute pancreatitis is the inflammation process in which proteins and lipids and digestive enzymes become activated within the pancreas and begin to digest the organ itself. Very, very painful. The most common cause is excessive alcohol consumption. Other causes is gallstone obstruction and bile flow. And on an x-ray, it looks normal. So my mom deals with acute pancreatitis. It's going to chronic pancreatitis because she keeps getting it. And they always ask her, how much do you drink? And she's like, I drink 1 drink a month. She's like, I'm so embarrassed. And so they keep attributing it on her to alcoholism, but and we can't find any stones. So she just randomly gets it, which is very, very odd. So if we look at a CT here, we have the axial. And this is the pancreas right here. Now the pancreas should look very structured. So you should be able to see the walls like this right here. So you should see that all the way around. So here's the head of the pancreas and then the body, and you have the tail over here by the spleen. So you can see it's all fuzzy. And what it's doing is it's leaking digestive enzymes, which is really, really irritating to the bowel. The bowel doesn't like it, so it's very, very painful. Now, there's nothing we can do for these patients. You just pray that they make the corner and the pancreas stops oozing all these juices and stops the inflammation, and they recover. So it can go either way. So not every patient are we able to treat. Really, the way we treat them is with fluids. We want to keep them hydrated because they're usually vomiting constantly. So sad. All right, chronic pancreatitis. So chronic pancreatitis results when frequent injury to the pancreas causes scar tissue. Reoccurring episodes usually result from chronic alcohol abuse, but like in my mom's case, so never judge. My mom doesn't drink. So this is, it can be caused by unknown. It's just the pancreas just gets really upset and has a fit. So usually it's from alcohol. It causes the gland to lose its ability to produce digestive enzymes, insulin, and glucagon. So the 3 symptoms are, acute pain. It is very, very painful. Malabsorption, causing weight loss, and it can cause diabetes. So this is what it looks like here. So this is chronic. So you can see the calcifications within the pancreas. So all in here. So all that is calcifications from scar tissue going into the pancreas. All right, pancreatic pseudocyst. So pancreatic pseudocyst is defined as a walled-off fluid collection. They occur due to inflammation, necrosis, or hemorrhage, and it causes acute pancreatitis, and it can be from, acute pancreatitis or trauma. And this is what it looks like. So we've got a big, huge walled-off area of fluid. And here is a pancreatic head. Normally it's real small. So here, this big, huge thing is pseudocyst within the pancreas. So yikes. Okay, cancer of the pancreas. The most common type of cancer of the pancreas is adenocarcinoma. So if you ever get a test question and it's like, what is a deadly cancer? What is the most common cancer? Always pick adenocarcinoma. So in the colon it is, in the esophagus it is, in the stomach it is, in the pancreas it is. So adenocarcinoma. Usually advanced at the time of diagnosis, so the prognosis is poor. So usually when we find patients that have cancer of the pancreas, it sits, doesn't give any signs or symptoms, and then it's metastatic. It's throughout the whole body. So you can't live without your pancreas. They have resected pancreases and had success in people living beyond 5 years. Usually it's a deadly cancer. It's not something that you want. So most common site is in the head of the pancreas. Other less common tumors are the ones listed there. So here's an ultrasound of it, and here is the head, the cancer in the head of the pancreas. All right, so right here and right here. You can see how ugly this one looks. This one doesn't look too ugly. We've got a couple chewy gooeys over here, but this one just is ugly, nasty looking, so not good. And here are your pancreatic summaries. Okay, pneumoperitoneum. So pneumoperitoneum is defined as free air in the peritoneal cavity. It's causes from perforation of gas-containing viscous, or it's a surgical emergency. So, yeah. Anyway, so this is the main thing, is that you know what this looks like. So air peritoneum here, so you can see here's the diaphragm. So there shouldn't be any air on this side. So here on the left side, we have the stomach. So we're always like, all right, we have a gas bubble always in the fundus of the stomach on an upright chest x-ray or abdomen x-ray. But there shouldn't be any air here on the right. So you can see that's called free air right there. It's air peritoneum. All right, pathology of the spleen. So, the one thing I do want to say about the pneumoperitoneum is that it's a sign that there's a perforation somewhere within the GI or in the hepatobiliary system, and that you need to take that seriously. All right, pathology of the spleen. We have enlargement and rupture, so easy, only two. So splenomegaly is enlargement of the spleen, is associated with numerous conditions, including infection. It can be from endocarditis, tuberculosis, malaria. It's connective tissue disorder, so neoplastic hematologic disorders. It can be from lymphoma or leukemia. It can be hemolytic anemia and portal hypertension. So splenomegaly, so if we're looking here, this is the liver over here. So this is the right side, this is the left side. So look how big this spleen is. It should only be about this big right here. So you can see it's definitely enlarged. So we need to sit up and pay attention to that. What's going on? What's causing that spleen to be enlarged? It's usually not just enlarged on its own. It's due to some kind of pathology. Splenic rupture. Most common cause of splenic rupture is from trauma. So rapid blood loss usually requires immediate surgery. It may be a complication of palpitation of the spleen enlargement by infection, so mono or leukemia. And we can see here all of this little area. So this is the spleen right here. This is the stomach. We put contrast in there so we can see it. And then you can see all in this area right here is blood. So that means this patient is bleeding out and we need to get them care immediately. All right, there's the two different disorders of the spleen, and that wraps up your hepatobiliary PowerPoint.